This bill would require acute care facilities and nursing homes to implement nurse-to-patient ratios in nursing units.
Ms. Corwin,
Thank you, Madam Speaker. Would the sponsor yield?
do you yield?
Sure.
She yields.
Thank you, Aileen. Just real quick, we've seen this bill a couple times in the past, but if you could just remind us, the staffing ratios that are outlined in the bill, where did that information come from?
There was a study group that looked at the different units in the hospital, and in fact, like ICU or CCU, and I think California, and there's other states that have done it. So a lot of the numbers have come from the experience of other states with other staffing ratios.
Okay. And you create a committee to study and make recommendations, but at the same time, you're also outlining specific ratios. So what would be the purpose of having the committee if you've already gotten the ratios lined out?
Because we want to see how effective the ratios are. You know, we can always implement change if necessary, but right now we know that appropriate staffing prevents nosocomial infections. Often the readmission rate is lower. Also, it's very important that we do teaching while a patient is in the hospital. And, you know, sometimes we hear the stories of people pushing the bell and nobody really coming to answer. And we want to make sure that all patients have appropriate quality care. And that's what this guideline is all about.
Okay, so the idea is the existing research states that this particular level of ratio is appropriate, but we want the committee to have the opportunity to make modifications, but yet we only allow them to make the ratios more, not less.
That's correct.
Okay.
That's correct.
So we're not really relying on research or data to drive this, because otherwise we would allow them the flexibility to go either way.
Well, I think when we look at California, when we see, you know, the world was falling apart when they did these staffing ratios, and what we found out, rather than losing money, they actually had a 3% increase in profits, and they found that there was less readmissions, less post-operative infections, and the quality of care was much better.
Okay. In New York State, we have a problem with staffing shortages. We have a shortage of nurses, and I believe that's true nationwide or in most areas of the country. Now, this bill would outline and require additional nursing staffing across the board. Really, all hospitals would most likely be affected by that. If we don't have those nurses available, how do we meet those ratios?
I think that many nurses are burning out early, and we've known that for a very, very long time. You know, when you are licensed and your license is in jeopardy and you don't feel that you can provide the quality care that's necessary, many people leave the field very early. I think that right now, I know that I represent 2 colleges that offer a 2-year program. We're also looking for a baccalaureate degree, and our programs are full each and every year. And I also think that as a woman's profession, they're not expanding those nursing programs, and I think that's very, very important. But right now, I can tell from my own personal experience at Orange County Community College and Sullivan County Community College, there are waiting lists. So maybe the answer to the shortage is to open more programs to make sure that we have enough spaces for nurses to be educated to become registered nurses in New York State.
Sure. Now, how soon after, assuming this bill becomes law, how soon after?
I just wanted to interrupt 1 second. There is no shortage right now in New York. As we look to the future, that's what we're looking at, a shortage in nursing.
Okay. This bill, once it's passed, how long from it becoming law until the acute care facilities are being held responsible for those staffing ratios? How much time are we allowing them to staff up, I guess is my question.
180 days.
So inside of 180 days, they're going to have to make up all these so they're going to have to do quite a bit of hiring.
But remember what happened in California once they passed these staffing ratios. They had a flood of nurses go to California. So I would think that when we can, you know, give appropriate care, when it's more attractive to nurses to come to our area and take full-time work, I think we'll see that. And again, I think we'll see better quality of care. And you know, my mother was in the hospital, and of course, sometimes we all go to emergency rooms. rooms. And the fact is when it's an emergent situation, you need a certain patient to staff ratio. And often in emergency rooms, we don't see that. And unless we can give the quality of care that's necessary in a timely manner, I think that's what I think the intent of this bill is.
Sure, I can understand that, and certainly I can see the logic. I guess my concern here is we've already come to the realization that we don't have enough people coming through these programs. As you said, there aren't enough programs.
Well, right now, again, we don't have a shortage in New York State.
But we do, as you had said earlier, though, that we do have a shortage of programs, and I do know that as well. I have a daughter right now who's investigating the process, and we have accelerated bachelor programs and so on. They've existed for many years, yet we still don't have enough nurses nationwide. I don't think we may not have an extreme shortage here, but certainly we don't have an overabundance of them. But yet we're only allowing 180 days for these acute care facilities to staff up. So my concern is they're going to start getting held for these ratios when they may not be able to realistically hire quickly enough to be able to accommodate those ratios.
You know, I think there are more and more young people, both men and women, that want to enter the program, and I guess it's our responsibility to make sure that we can expand these programs in New York State. It had to be done anyway because, you know, we are aging out. All of our nursing programs are full, and so right now we're in a stage where we have to prepare for the future and make sure there are enough spots for enough nurses for the future, and that's expanding programs.
Sure, absolutely, and certainly any efforts you have to expand those programs, I certainly would support. I feel the same way with medical schools. We have a doctor shortage, and I've talked to physician friends of mine who are in admissions programs, and they agree that we have a shortage of that.
I'm also informed by the New York State Nurses Association and other organizations that they still have nurses that are looking for jobs.
Okay. Now, my concern here as well regarding the staffing ratio in the event that the facility is not able to staff up quickly enough or appropriately enough, what happens to the acute care facility? There is some sort of course of action that can be taken against them, correct?
I guess the Department of Health would investigate the cause. I mean, if it's an impossibility, I think that, you know, maybe they could extend the period of time. But I think that the fact that there are nurses looking for jobs, they are out there. And if we make sure that they're aware that these jobs are available, I think that a lot of those holes will be filled.
Okay. Now, I know some of the hospitals in my area have reached out to me. Their concern is also about cost. You know, if we're talking about staffing up, you're going to have to come up with a fair amount of money to be able to pay these nurses that are new to your system, and you only have 180 days to do that. Is there any kind of an appropriation or any kind of funding that would be available across the board to all of these facilities?
No, there isn't. But again, I would say that nurses are the backbone of our healthcare system. We saw an article in I can't remember what newspaper about the $72 million going to the management of hospitals. So I think there's a balance there that we can reach. So, and I think that it's important that, you know, we make sure that that happens.
Okay, thank you. Also, to get to the part about the work assignment policy here that you've outlined, allowing the opportunity for a direct care nurse to refuse an assignment if it's something that she feels is out, or he or she.
We can do that now, by the way, Jane. We can do that now according to our contracts. If you can say that it's an unsafe setting, and we can already do that.
Okay. I guess my concern here, though, is that now we're introducing a new concept that if a direct care nurse can refuse an assignment and the acute facility falls short in that area for a ratio, then they are now going to be held liable for something that really isn't within their control. That's something that the nurse herself has decided.
You know, nurses are very dedicated to the healthcare profession, and normally, if it's an unsafe staffing level, that they will sometimes, I can't remember, it's called something in the assignment. They'll say that they're objecting to the assignment. I'm sorry, I couldn't think of that word. And we can do that now. But honestly, most nurses, and I mean, if your parent or anybody is in the hospital that you love or you care about, you want them to have the appropriate staffing. And right now, it's just not that way. You hear patient after patient saying, I pressed the bell and the nurse didn't get there for 20 minutes. You know, and also I do want to make sure that we're aware that the CNAs, the nursing assistants, play a vital role in the hospitals. So I don't think, or I know that their job should be absolutely safe because they play one role and nursing plays another role.
Sure, absolutely. I agree with you. They certainly do provide a very, very critical function. And I guess my concern here, as always, is are we setting them up for success and making that happen, or are we setting them up for failure? I'll tell you honestly, right now, 8 out of the 9 private hospitals we have in our Western New York area are losing money already. I've been told by them that if this bill gets implemented, that they would have to shut down. That would be obviously a crisis situation if that's just in one region of the country or the state. So again, I think we have to do is, are we truly addressing the problem? And I'm afraid that this bill would actually make the problem much, much worse than better.
Well, remember in California, the same scenario was occurring, that they were losing money at that time, and once they implemented safe staffing, the profit margin went up at least 3%.
Did they provide any kind of funding or any kind of bridge financing to allow them to get to that point, though?
No. No.
Thank you. I appreciate it, Elaine. Thank you very much, Madam Speaker.
Mr. Goodell.
Thank you, Madam Speaker. Would the sponsor yield?
Do you yield, Ms. Gunther?
Yes. You know what?
She yields.
Thank you, Ms. Gunther.
You're welcome.
Is it your view that the healthcare system in New York, needs to hire a lot more nurses than we currently have employed?
Well, I think they need to hire more. I think it depends on what hospital. Each hospital is different. Do you have to hire more? I'm not really sure with each hospital across New York State. I'm sure some hospitals need additional staff, but I think some have appropriate staff. And again, you know, we know that some registered nurses are looking for jobs at this point.
Have you done an evaluation of how many additional hires would be needed statewide?
No, I haven't.
Now, this bill is called the Safe Staffing Bill, but in reality, it only deals with nurses, right?
Yes.
So it doesn't talk about the staffing ratio for doctors or physician assistants?
No. No.
Doesn't talk about the need for a ratio for respiratory therapists or lab techs or phlebotomists? Am I correct?
That you're correct.
Doesn't deal with radiologists or pharmacists or physical therapists or occupational therapists?
No, only the nurses, not the ancillary services, no.
And it certainly doesn't deal with cleaning, dietary maintenance.
No, and not plowing either and gardening, no.
So, and I understand that. So it's not really about safe staffing. It's about mandatory nursing, correct?
No, it's about safe staffing.
But it doesn't deal with any staffing at all. Doctors, physician assistants, no other staff of any kind except nurses, correct?
Correct.
So this is all about nursing staffing ratios, period.
Bingo.
Now I'm confused. What happens if the nurse...
Excuse me. Nurses usually work 8 to 12-hour shifts. The reason they call them backbone is because unlike a physician comes in, he does the examination, he checks on the progress, or he checks that there's not progress. A nurse spends 8 to 12 hours, so different. But if you think however, in the emergency room, when they're hired physician, there is a ratio in the emergency. Now, each emergency room is different. If you go to Columbia Presbyterian versus where I live in upstate New York, they wouldn't need as many emergency room doctors. Also, it depends on like the area that you live in. We have 70,000 people in Sullivan County, and there's 300,000 in Orange County. So therefore, depending on how many emergency rooms there are, that would also determine how many beds would be in the emergency room, and therefore the determination about how many doctors need to be on what shift would be the administration of that particular hospital. The same thing with a nurse. Remember, a smaller hospital doesn't require as many nurses. Also, it depends on the type of hospital. If you have a community hospital versus one when you do cardiac transplants, there's a whole different rate requirement regarding how many nurses. You could have
No.
2 nurses on one patient.
I don't mean to interrupt
so
you,
there's a lot
but
of, like, it's not an exact formula. You really have to use your head when you're thinking about the ratio.
and I absolutely agree with you that it shouldn't be an exact formula.
Right.
But your bill requires an exact formula, doesn't it? It says,
But
let me just
wait,
finish
now,
my
wait a
question.
minute.
Let me
You
finish
know
my
what? We
question.
talked about the
Ms.
emergency
Gunther,
room.
let me ask the question, okay?
Okay.
Your bill requires a 1-on-1 ratio for trauma emergency. It requires a 1-on-2 ratio for critical care, including emergency.
Right.
No definition in the bill between those two definitions or those two situations, and a 1-on-3 in emergency rooms, right? And that is a straight ratio.
Wait. So we are looking at this in terms of diagnoses. So a trauma emergency. Then we're looking at an operating room. When someone's a post-op critical patient. Then we're looking at intensive care. We're looking at that type of patient. So it's dependent upon the diagnosis and the type. And it's not like if you go down the line, you have a rehab. You have 1 nurse to 5 patients because the intensity of
Can we
the
look
care
at
is not
emergency
there.
rooms for just a minute? What's the difference between an emergency room or a critical care including emergency room? What's the difference? Is there emergency rooms that don't provide critical care?
Critical care is, yeah, there are some. Sometimes we divert patients to certain hospitals. If it's a rural hospital and they can't serve that patient, they might divert them from, say, Sullivan County to Orange County or to Westchester County because there's certain things that our hospital can't provide. Like, for instance, when somebody has a stroke, sometimes some of those are in stroke centers, so we would divert that patient. So it's also, you have to use your head and intelligence to see what type of patient it is.
So let me ask you, because I was confused on how this works in practice.
For instance, in Sullivan County, we have a
Ms. Gunther,
critical
please.
access hospital.
Thank you. So here's my question.
Okay.
Your bill requires a 1-on-1 ratio for trauma emergency units and a 1-on-2 ratio for any critical care areas, including an emergency room. What happens if a hospital is maxed out? Let's say they have 5 nurses and 5 trauma care patients, and there's a car accident, and one of the individuals is hurt.
This is an easy one. So
Okay.
the ambulance calls in and says, we have a car accident. The hospital's filled. We put the hospital on diversion, and then automatically you don't go to that hospital. You divert to another hospital. That's something we do in an emergent trauma. If there's an outbreak, if there's an explosion, that you have a certain amount of beds and a certain amount of staff, so you can divert some of the patients.
Thank you, Ms. Gunther. I appreciate those comments on the bill.
On the bill, Mr. Goodell.
I have a rural district. I have 3 hospitals that offer. Well, I have 4 hospitals that have some level of emergency care. If I'm in an accident, in a car accident, and I trust this probably applies to most of you. If you're in a car accident and you need emergency care, you want to go to the closest emergency room and hope they'll take you in. And under this bill, as the sponsor explained it, you go to the emergency room or you have the ambulance coming to pick you up, and that emergency room says, I'm sorry, we don't have a 1-on-1 nursing ratio for you. Sorry about your trauma. So what happens? In my county, the next closest hospital is 45 minutes away. You call ahead. When I go to get dental work, I make an appointment a week or 2 ahead. Same with my primary care. But I don't call the emergency room a week ahead and say, guys, I'm planning on having a trauma accident with my car next Tuesday at 4 o'clock. Do you have the staffing lined up? So what happens then? So then we have the emergency ambulance calling all the neighboring hospitals while I'm bleeding out in the back? Thank you very much. And if none of my New York hospitals are available, then what? They star flight me to Pennsylvania? You know what? Pennsylvania will take a trauma patient. They don't run a nursing ratio before they say, yeah, we'll put you on life support. That's what this bill requires. But now you may be thinking, oh, it's not that complicated. We'll just take a nurse from a different unit and transfer. Really? Read the bill. Because the bill says the nurse can say, I don't have any experience in that area. I'm not going. Now, what if the hospital insists and says, if you don't go, you're fired? We have a private right of action in this bill. Not for the patient who's bleeding out in the ambulance, not for the patient who can't find a hospital. We have a private right of action for the nurse to sue the hospital and get damages and liquidated damages, doubling her damages, if she can establish that she should not have been transferred to help out. And she gets legal fees. I love that part because I'm a lawyer. Of course, the hospital doesn't get legal fees if it shows that it's correct, only the nurse. So on one hand, we're told we don't really have a nursing shortage. On the other hand, we're told that we have to adopt this law to put in these ratios. If we don't have a nursing shortage, we don't need this law. If we do have a nursing shortage, we're going to have huge costs. Our estimate is the cost will be in the range of $3 billion. Now, nobody here is talking about changing...
Ms. Walker, why do you rise?
Will Mr. Goodell yield for one quick question?
Do you yield, Mr.
Certainly.
Goodell?
Do you have more data on the cost of adding these nurses?
No, actually, I heard you say that you were an attorney.
Yes.
And you were making a comment about a nurse's right to protest an assignment. And,
Under this bill.
Under this bill.
Not only can protest, but can refuse to take it.
Well, as an attorney, and speaking from a fellow attorney, don't we as attorneys have a right to refuse to take a particular client if we feel that we don't have the proper capabilities or the
yes.
ability to be able to handle adequate representation of a client?
Absolutely. And here's the difference. When I don't take a client, they're not dying in my waiting room waiting for health care. That's the difference.
Well, most people from...
So I refer my clients, if I have a client comes in with bankruptcy, I say, really sorry, I don't handle that. Here's some experts. Good luck. They don't die in my waiting room. I don't say, sorry, you have a trauma, but the next closest hospital is 45 minutes. Wait while I call them to see if they can take you.
Well,
I don't say, wait a minute, let me call in a medevac because the closest hospital they'll take you is in Pennsylvania.
I think that's
the difference between lawyers.
Extreme cases here. And if you have a right, or I have a right as an attorney to be able to say that I don't have the proper and requisite abilities to be able to do something, that I can ask someone, will please allow me not to have the opportunity to take this client, or I can refuse to represent someone.
Right.
I think that we should allow for our nurses to be able to do the same thing. Because truth be told, if I was in a waiting room and maybe dying, I would want somebody who has the requisite skill to be able to provide nursing care to me in the first place.
Absolutely, and I appreciate your comment, and thank you for that observation. My hospitals in my district have an adequate ratio to ensure a high level of quality care, and that's reflected in their certifications, it's reflected in their outcomes, and it's reflected in what they do. What this bill says is that we, by legislation, know better what the patient mix is in my hospitals, that we as a legislature can dictate what the nursing levels need to be and override any decision that might be made by the hospital administrators who's balancing the need to have phlebotomists and pharmacists and radiologists and physical therapists and all the other staff that make up a high-quality, high-performing healthcare team. And that's the problem with this bill. If we want to focus on patient care, great. Let's focus on patient care. Let's look at what the outcomes are. But if you've got a hospital that makes great outcomes because they balance their patient mix with their staffing levels and operate successfully, that's the model we want. There's no funding in this bill, by the way, to hire additional staff. None. There's nothing in this bill that changes the Medicaid reimbursement rates, which, as you know, are not on a fee-for-service basis. There's nothing in here that would require insurance companies to pay for any additional staff. A few weeks ago, we debated a situation where hospitals were closing because they were running out of money. This is a great bill for them because all they have to do is lay off a few staff and then we'll close them for them. And we won't let them provide any care. So I appreciate that each of you have your own hospitals in your own districts. And I have no problem, by the way, if you want to adopt a bill that deals with just your district. But please, don't tell the hospitals in my district that they cannot take any of my friends or relatives or myself into the emergency room if they don't have the mandated staffing levels for just nurses that this bill would call for. Thank you, Madam Speaker.
Mr. Morelli.
Mr. Morelli.
Thank you, Mr. Speaker. The members of the Government Employees Committee should move to the Speaker's conference room. Mr. Body is prepared to have a meeting of government employees in the Speaker's conference room.
Remix. Government employees, back to the Speaker's conference room. It's your fault. It's always your fault.
Mr. Rea.
Thank you, Madam Speaker. Will the sponsor yield for a quick question?
Will you yield, Ms. Gunther?
Sure.
Sponsor yields.
Thank you. You referenced California a number of times with respects to this legislation.
Yeah.
Can you tell me what the differences are between the California legislation and our bill?
Do you want all of it? There's a list. I'll just give you a couple. In medical, surgical, and acute psychiatric, it's one nurse for 4 patients. And in medical surgical, this is New Jersey. Do we have? Oh, it's the same bill. Okay. So New Jersey and California, it's 1 RN per 6 patients and a 5-year phase-in. Step down is 1 nurse.
Okay, can we stop there?
Yeah.
So what's the phase-in here in New York?
There isn't a phase-in.
So California had time to prepare their hospitals for this process, and here we're just kind of asking New York hospitals to jump on this in 180 days, right?
Yes.
What also, I think California has limits regarding...
They only have the phase-in for the one department in California and New Jersey, by the
But
way.
California's bill actually deals with, they set restrictions on individual nurse specialties, correct?
Didn't hear that, please.
The California bill actually mandates sets mandates for individual nurse specialties, doesn't it?
Yes.
But this bill doesn't.
ER trauma, behavioral and psychiatric, intensive care, neonatal, OR, we have post-anesthesia, labor 1 stage for the first, labor 2 stage, and then for the last stage, 1 nurse per 1 patient, postpartum. So we do kind of in the nursery, pediatrics, so we kind of do the same.
Well, those are not, in other words, nurses can be specialized in certain areas, not just have experience working within those units.
Well, normally when you have an assignment, usually like if you're an OB nurse, you usually stay on OB unless there's some sort of a strained situation. But normally each person has their own, like when they do the staffing, they usually, like I would be staffed to OB, another nurse would be staffed to the ER. That's the way it goes. And unless there's an emergent situation where you have to float somebody out because something's happening, if there's a tremendous bus crash or something like that, or what we had seen in Florida with all those shootings, then everybody would come to help. But normally you have...
But under this bill, they wouldn't have to come and help.
There is an emergency exemption in this bill. I can read it to you.
Okay.
The facility shall establish a consistent plan for addressing emergency staffing situations, declared emergencies, mass casualty incidents, or other events not reasonably anticipated and planned for and not regularly occurring within the facility. So there is a part of the bill that does address exactly what you're saying.
Okay.
Thank you.
Thank you.
Ms. Peoples-Stokes.
Thank you, Mr. Speaker. Would a sponsor yield for a quick question?
Will you yield? Sponsor yields.
Yes.
Thank you, Aileen. I was just want to ask a little bit about the California experience as well. I think I heard you mention that they increased their profits by 3%.
That's correct.
So did you have in their report, what was that based on? Was that because what? I mean, what was that based on?
Well, patient outcomes have improved. And basically, I think that the reason that there's a profit is patient satisfaction would be number 1. So, of course, you're going to use that facility. Secondly, if you have a readmission within 30 days, then your insurance won't pay for it. So if you do appropriate teaching and appropriate care while someone is in the hospital and there isn't a readmission, so you save money on that. And I think just quality care improving the quality care in your hospital, of course, there won't be any unanticipated events.
Okay, so
Let,
in your
also,
previous
there's
experience-
workman's comp. Remember all the nurses that were hurting their backs because they had short staffing? So workman's comp is a big thing. Like staffing satisfaction. So if you're not retraining one nurse after the other, saves the hospital a boatload of money.
Okay, so in your previous experience, I would have to believe that you saw patients, who chose a hospital based on the kind of service that they got.
Absolutely. And that's why, like every Joint Commission, they talk about patient satisfaction, and they usually ask them as they walk out. And, when patients aren't satisfied, and it's not only the patient, it's also the families aren't satisfied. They're not going to use that facility again unless there's no other choice.
So
I think that's very important.
Just to be honest, there are some communities in the state of New York where there are not multiple hospitals, where you don't necessarily have a choice. But I know that there are also some people in communities across the state of New York who will choose to even go to another state, to a hospital, because they believe that they'll get a better service there. And I mention this because, I think I have mentioned this on the floor before, that my daughter is actually on the list for a transplant. And more than once, people have come to us who have had transplants from Buffalo, but they didn't have it in Buffalo. And so I think what this speaks to, and quite frankly, what the increase in profit in the California hospital speaks to, is that people will go and pay for what they think is the best. And if you're going to get a better service, you're going to go to the hospital where it's going to be delivered at. Now, that's not to say that we don't have great hospitals in Buffalo, because we really, really do. But there are, in fact, people who will choose to go to Pennsylvania and Cleveland for transplant issues as opposed to staying there. And I think that's because they feel like they're getting a better service, they're getting a quicker service, they're getting that transplant a lot quicker than they can in Buffalo. The other thing I want to thank you.
Welcome.
Aileen. On the bill, Mr. Speaker, I think that this is probably one of the most important topics that we've discussed of recent, because there's not many of us in here who has not had a loved one in the hospital or who has been in the hospital ourselves and had the occasion when you actually were looking for a nurse and there wasn't one available. That doesn't mean that there's not a nurse, that there's a nurse slacking off somewhere. That means that a nurse really just legitimately has too many patients to see. And I know that there's some hospitals who handle this better. There's some in my district who think that this is done fine and they don't have a problem with it. And I can't say that I necessarily disagree with them, but I can say that I've had people in the hospital and looked for a nurse and couldn't find one. And when I did find one, what I found is one of the best caregivers ever. It's more difficult to see your family's doctor in the hospital than it is to see your family's nurse. And so I think that it's important, as Aileen Gunther said, that nurses are the backbone of health care that's delivered in a hospital and anywhere else in this world. And whatever we can do, I think, to enhance the quality of their work and the quality of their life on the job is something that we should be considerate of. And I think at the end of the day, much like California, hospitals in Western New York will see profits. Hospitals in the state of New York will see profits because people are going to want to come where they get the best service. It's not like there are boatloads of folks that are getting health care for free. Somebody's paying for it. And if we want to get good health care, we have to be asking for the best people working with us. And I think we do that when we do a fair staffing plan for nurses. And so I want to commend the sponsor on this piece of legislation.
Mr. Castorina.
Will the sponsor yield? And please don't say respectfully no.
Will you yield, Ms. Gunther? Ms. Gunther yields.
First of all, I'd like to applaud the sponsor for this legislation. I've wrestled with this legislation for quite a bit since I came to know about it. I come from a district that has only one hospital, and it's an annex of a larger hospital. And what I'm concerned about is whether or not the economics will provide for this hospital to continue with this legislation and not end up being shut down?
I have to just ask you, it's not an annex, it's probably a critical access hospital, and they get usually enhanced rates anyway. So if there's a larger hospital, like we have Catskill Regional and we have one in Callicoon, normally a critical access hospital, it's a 3-day length of stay, and then what happens is they get enhanced rates to begin with. And so depending on the diagnosis and what they hear from the ambulance, they might go to the critical access to stabilize and then move them over.
I think that nurses are truly angels. They do work that
Thank you.
really we would be, I don't know where we would be without them. There's no question about that. And I think that this bill is important for nurses as well. And they need to be commended and they need to be respected, because I do think that they are put in a position where they're serving too many patients and they can't be effective. But what I am concerned about is in the event of, God forbid, a tragic situation in my community where we have nearly 150,000 people and we have just this one annex of a hospital, what would happen in the event, God forbid, of an emergency where there were nearly 100 people that were in critical care and needed emergency services?
I just read that portion of the bill about addressing emergencies, and if there's a catastrophic event, no matter what, they go out to other hospitals and they all join together. The EMS, the critical access, they call in physicians. They usually have a plan. Remember with bioterrorism,
right,
how that in emergency management plan in a community, everyone is mandated to have it. So in a situation like that, that plan is in place, thank God, when we had different outbreaks and things like that. So I wouldn't worry because we already have a plan in place everywhere.
Now, in that instance, God forbid, as we said, where perhaps maybe a hospital would accept more patients and nurses would take on more duty, and with this legislation, they might be compelled under law and under perhaps some liability factors to disperse patients, and then that dispersion may cause more time to intervene in between the time that they're picked up by emergency service personnel and seen by emergency services in emergency room.
That's not really how it works. Or every hospital, every community has an emergency management plan. It's done through the county that you live in, and it goes down the line with your Department of Health. Everybody's on the same wavelength. So if there's an emergent situation, first of all, the bill addresses it. And secondly, we all have, because of bioterrorism, because of the 9/11s, we all have that all in place, just like what we saw in Florida when they had this massive amount of patients going to Florida to that hospital. What happened was immediately surgeons were called in, nurses were called in. They have all those numbers, and that's exactly due when you have a bus accident or some kind of major incident. There's already, the preparation is there, and we also have drills about preparing for these types of things in every community, which is very, very important.
And lastly, Ms. Gunther, do you think that this bill might be more effective and more compelling if perhaps there had been maybe some impact studies on communities as to what would happen economically to the local hospitals? Do you think that maybe, because that's my personal opinion, that this bill would be more compelling if I had in front of me some type of research that showed what the impact would be economically to the local hospitals, if I knew that the impact would not be so severe and would not perhaps maybe cause them to close, I'd be very happy to vote for this bill. But in the absence of that, I'm just, very concerned, and I wonder if perhaps you think that maybe it would have been more compelling to have that type of information after thought. Thank you.
I'm just going to comment on that. You know what? We always say that, good health care is a human right. And I think that the compelling part of this legislation is no matter what area you live in, whether you're in the richest area or the poorest area, whether you're the most rural area or you're in a big city, we all deserve the same level of care in those units, whether it's critical care, emergency care, OB care. We all deserve that. And I think that this will bring equality to the healthcare system.
Mr. Garbarino.
Mr. Speaker, will the sponsor yield for a couple questions?
Will you yield, Ms. Gunther? Ms. Gunther yields.
Thank you, Mr. Gunther.
I'm going to come over there.
All right, I'm sitting down now. I think Mrs. or Jane asked this before, but can you answer how did these numbers come up? How did you come up with the numbers 1 for 1, 1 for 2? How did you guys come up with it for the bill?
You know, I think we followed some of the California and the New Jersey numbers. And I think that we look at, I think that there are smarter people than I am that, set these numbers up because they looked at acuity in each unit and felt that this was the appropriate level of care. And, this didn't come about in a day. This is something that's been studied for a very, very long time by the Joint Commission, by the Department of Health, by, people that are a lot smarter than I am. And I think that, again, just like every law, we're putting this in statute. But remember, after a year or two, when we have this commission that is looking at, outcomes and looking at how the efficacy of what we're doing, that what we can do is we can always, amend a bill. But right now, we think this is a good way and a good way to start. And again, Mr. Garbarino, there's always the chance that, we can go back in another year and say, this is adequate, it's not adequate, we're overstaffed in one unit, not staffed enough. So I think that we look at the outcomes after a year or in a 2-year period, that we'll be able to make sure that these numbers are as appropriate as possible.
So are you saying these numbers that you're using today came from a study that was done?
Yeah, and we looked at New Jersey, New York. We looked at their outcomes. We looked at their success rates. We also looked at different units in the hospital. You can see by the Joint Commission, there's a lot of places. There's many people that studied it. I didn't myself, and they came up with these numbers.
Okay.
So it's not something that they picked out of thin air. It's something that's studied, and they think this is the appropriate staffing. And New York always does it better, always.
Well, sometimes. Another question I have. Currently, are hospitals required, specifically emergency rooms, are they required to take people that show up? They can't turn them away, correct?
That is correct. They and what they do is, in every emergency room, and this is in place right now, as you walk in the door, before they ask for medical insurance, before they do anything, they triage the patient. They look at if they're a priority patient, some can wait. If they're not a not priority patient, if you have a splinter in your foot or something like that, and then they're already screening these patients and triaging these patients. So we do that
but they're required to take them. If they take Medicare,
sure, but
they're not
sometimes
allowed
we have to wait,
away.
as you know, depending on the triage and how many people are in the emergency room. And sometimes they can call staff in, per diem staff, etc., if necessary.
So here's the question. Say a hospital has 100 beds in its emergency room.
Okay.
How does this bill? Is that a lot? I wasn't.
100.
All right, how many?
Lord
Did you work in a hospital?
I'll say. I would
correct?
say we'll give it a rural hospital 20.
All right,
25.
20. So there's 20 beds in the emergency room. How does this bill not turn into the hospital saying, well, federal law requires us to take anybody that shows up to an emergency room. So you know what? I better have, if it's 2-to-1 staffing under this law, I have to have 10 nurses on staff in the emergency room. How does this bill not turn into, you know what, we are now going to safe staff according to beds, not patients? Because if a hospital is going to worry about having to kick someone away because they don't have enough nurses, but they need to take them because Medicare requires them to, they're going to say, all right, 20 beds, 10 nurses. What happens if at that night only 10 people need to use the emergency room beds? They have 10 nurses for 10 people. They can't put any, under this bill, unless the nurse says okay, they can't put that nurse anywhere else in the hospital.
You know, staffing, you know what, there is a trend factor. You have flu season, you know, the emergency room increases. And the Catskills, in the summertime, we know that our population triples, so we increase. So, I mean, it's based upon formulas, intelligence, and a trending factor. And you can always call in per diem nurses. We also have visiting nurses that we sometimes call upon. So we really have plans in place as is. And this is just going to make healthcare in New York State a heck of a lot better. Women won't leave the field, or men won't leave the field sooner than they would really like to. And number 3 is our license is on the line. And you have to remember that, you know, when I go to work as a nurse, I want to do the best job ever. I don't want your mother to be in pain. I want to be able to address that situation. And I can only do it and do it in the best possible way if I have appropriate staffing. And you know what? It's almost that you have to be in that spot. And you have to see somebody like your mother not getting, and you're going to say, man, I wish we had staffing.
No, I understand. I have nothing against nurses. My grandmother was a nurse. 3 of my aunts are nurses.
I love your grandmother.
They would not. Was that a question? No? All right.
I didn't say that.
No, all right. No, I was wondering if somebody had a question. So I'm not asking about whether or not, you know, the nurses are doing the correct job. I'm talking about the proper use of resources. So if my question is though, if a nurse, if this hospital's putting 10 nurses for these 20 beds and they don't need them, under this bill, they can't just move them wherever they are needed. So you're going to be wasting resources here. I mean, is there any concern about that at all?
You know, as a nurse, if there was an emergency situation in another unit or the need for more staffing, you can float nurses. You can float.
But under this bill,
you can float them back and forth. You can absolutely do. If you in an emergent situation, you can float. The other thing is, if you're overstaffed, there are a lot of nurses that will take the day off. They'll be very glad to get a day off. So you know what? As long as you staff your area to the amount of patient, you look at the trend factor. I mean, there's nothing more you can do. It's just like anything else. When you have a restaurant, you know that the breakfast is heavy, but the lunch is not so heavy. So it's the same difference.
But I mean, in a restaurant, you can plan for, you know, Christmas dinner is going to be packed. In an emergency room situation, you really can't plan for when a trauma happens. I mean, or when a big, some awful accident happens.
It's exactly what it is now. But sometimes nurses and emergencies are overloaded, and sometimes you want to do the very best you can. This is a bill that will make health care in New York State a better place. The only thing I can say to you is they did it in New Jersey, 3% increase in profits. They've done it in Pennsylvania. They've done it in California. There's about 10 states they've done it in. And you know what? The outcomes have been very good. And I think that the proof is in the pudding. You know, when we look at, you know, scientific studies, we look across the board about what works effectively and what doesn't. And this works effectively, and I think it's important that we pass this bill tonight.
No, I understand that, and you came up with, and you had said before that we have these plans, we seem to know when there's the high season, when there's the low season. But what happens if there is a major trauma, there's an accident somewhere, there's a lot of...
the same thing that happened, it was the same thing in Florida.
Gunther, can I please finish the question? I just have a question, please. Here, the bill says, a nurse who refuses an assignment shall not be deemed by any reason, therefore, to have engaged in negligent or incompetent action. So if the hospital cannot move a nurse from another floor to the emergency or trauma area, and the hospital, because of this bill, does not have enough nurses to cover the patients going to that area, has to turn somebody away, and God forbid that person passes away on the way to another hospital where there are beds or nurses available, the nurse is not liable, but would the hospital be liable in that situation?
You know, again, I would say that in this bill, there's 3 or 4 lines that address an emergent situation or a special situation. It addresses it clearly in those 4 lines as I read before.
So in an emergency situation, a nurse under this bill cannot refuse to go?
In an emergent situation, I think we, as nurses, we take an oath to be a nurse, and I think that in an emergent situation, the bill addresses it, and I think as we take an oath as a nurse, and you know what, that doesn't really happen in an emergent situation, and the bill does address that.
Okay, thank you.
Thank you.
Ms. Bashot.
Thank you, Mr. Speaker. On the bill?
On the bill, Ms. Bashot.
First of all, I want to thank the sponsor for introducing this bill. I think this bill is crucial. It's definitely needed. Nurses are the cornerstone and the backbone of our healthcare system. And quite frankly, in most of our community hospitals, our nurses or our hospitals are not adequately staffed. I know this firsthand. My mother, just recently, who was in a hospital, fell off the bed after pressing her button, and she fell off the bed because she needed to use the bathroom. No one was able to attend to her needs, and so she got up and she fell. Now, of course, when she fell, they ran to her, but then immediately after, she needed to get a CAT scan, x-rays, because they wanted to make sure that she was okay. There weren't any blood clots or anything. So here, there's an example of where, because this particular hospital was not adequately staffed, the cost risk increased. So instead of staffing appropriately, the hospital now had to spend money on other procedures, as well as risking not having my mother come to the hospital anymore. So that's the risk. There's a cost risk and an opportunity risk. Now, we talked about, how will a hospital be able to be economically sustained? Well, as we know, many hospitals, CEOs and administrators are being paid high salaries. We need to look at how we're going to reallocate the overall budget to allow quality care. Now, in our community, one of the reasons why this is very important is because, first of all, many of our hospitals are being closed. Our community hospitals are very dense, primarily because of socioeconomic disparities. We have issues with gun violence. We have issues where poor communities don't have the option of healthy living and healthy food. So there's high diabetes intakes and high blood pressure intakes. We have a lot of seniors who, again, not adequately secured or insured. And so they go to the hospital. And so when you have community hospitals such as the hospitals in my district, you're going to have a burden or abundance of patients. And it's very important that we take a look at being able to service those patients. In addition to that, in my district, nursing is the #1 profession that is sought. However, jobs are not available. So this bill, to me, will do 2 things. It will provide adequate and quality care. It would also address the economic disparity. So, Mr. Speaker, I completely support this bill, and I will vote in the affirmative. And I thank the sponsor for introducing this bill. Thank you.
Read the last section.
This act shall take effect on the 180th day.
Clerk will record the vote. Ms. Walker to explain her vote.
The things that I can always speak about is just my own experiences. And one thing that was experienced in a hospital in the neighborhood that I represent was that there was a nurse who was severely attacked. She was attacked to the point where she required a significant hospital stay herself. And it's basically because she was put on a ward that she wasn't prepared to be able to handle. And if this particular law had been in place, she would have had other mechanisms that she could have utilized to say, this is something I can't handle, and maybe she would not have gone in harm's way. I was also hospitalized one time, and there was a nurse who provided a certain level of care for me that I know that her special attention that she gave me brought me through the medical attention the medical situation that I needed, which was very, very severe, because a year later, someone else who's about the same age as I was died from the same condition that I had, that my nurse brought me through. So I think this is very important that we are able to provide the type of attention that our nurses need, because we want to make sure that they're not overworked and burned out in a position where they just cannot provide the quality of care that our communities so heavily desire. So it is my honor and my privilege today, on behalf of the nurse who helped save my life, to be able to vote in the affirmative on this very important bill. Thank you. I vote yes on this piece of legislation.
Ms. Walker in the affirmative. Ms. Nolan.
Mr. Speaker, my colleagues, just quickly to congratulate the sponsor on a great job and a great bill. But we got a call in our office, I must share, from a 96-year-old retired nurse who lives in my Assembly District. And Ernestine, this is for you and all the nurses who work so hard. She was totally in support of the bill and wanted us to know, so I vote in the affirmative.
Ms. Nolan in the affirmative. Ms. Jaffe.
Thank you, Mr. Speaker. I am in firm support of this legislation because I believe that safe staffing is a public health and safety issue which cannot and should not, in good conscience, be ignored. I have great respect for our nurses and their diligence and their focus and their commitment and their strength to our patients in our communities. Research has consistently demonstrated that when nurses are assigned more patients than they can adequately care for, those patients, our loved ones, our friends, our neighbors, are at greater risk of death, infection, complication, falls, and readmission to the hospital. Nurses are key to improving patient outcomes. We must act to improve their working conditions and to establish a minimum safety standard and expand job opportunities, which will be a result of this as well. I want to thank the sponsor for her focus and extraordinary response on this legislation. Now is the time for us to pass this legislation. Patients in New York State hospitals and nursing homes, their families, and our dedicated nurses deserve nothing less. I will vote in the affirmative.
Ms. Jaffe in the affirmative. Mr. Robinson.
Thank you very much, Mr. Speaker, for giving me the opportunity to explain my vote. I stand at this time in the spirit of my mother, Anna, who was a nurse. I also stand for my granddaughter who graduated from nursing school just last week. And so she will be one of those that's going to be taking on the responsibility of caring for patients. I believe that a trained and caring nurse is the best medicine that someone could receive. I know that over the past few years, we've been actively engaged in saving a community hospital. And one of the concerns of those that went to the hospital as we reviewed what was needed was that people talked about they wanted a trained and caring nursing staff. That is most important. My mother used to say to me about how that if you don't have, when you come on the ward, at that time there was wards and you had maybe about 20 to 25 people that you had the responsibility for, which was too many, and you had maybe 2 nurses to take care of those 2 people. But now we're talking about a different kind of staffing ratio. Things have changed, and we need to make sure that people are cared for in the proper way with the safe staffing that is required to be able to make them healthy. People who see a nurse and a nurse that talks to them as it has been described, someone that talks to them and helps them through the process. That's what training is all about. So I want to commend the sponsor on this legislation and look forward to us passing this evening because when people are sick, they need someone to care for them and to make sure that they get better. So I will vote in the affirmative on this piece of
Ms.
legislation.
Robinson in the affirmative. Ms. Richardson.
Thank you, Mr. Speaker. Today I rise in support of this piece of legislation. I would like to commend the sponsor for introducing this. I consider this to really be common sense legislation because it's the right thing to do. Any one of us in this chamber would want the best quality of care if we were admitted to the hospital with the proper expertise given to us depending on our condition. I represent 3 hospitals and I adopt 2. Let me shout them out now: SUNY Downstate, Kingsbrook Jewish, Kings County, Interfaith to the North End, and Brookdale. And I have heard time and time again from so many of the nurses the ordeal that they have to deal with day in and day out of dealing with too many patients, and they're just scrambling, and they are serving from their heart, but they are not given the opportunity of time to spend with their patient and to provide the quality of care that they know that these patients deserve. So I stand firmly here today with you, Ms. Gunter, and the rest of the body, as I vote in the affirmative, and all the nurses out there, this one is for you. Thank you.
Ms. Richardson in the affirmative. Mr. Weprin.
Thank you, Mr. Speaker. I'd like to be excused from voting. To explain my vote, I am a proud co-prime sponsor of this bill, have been for a number of years. I do so and support this legislation not because of the high respect I have for the sponsor who fought so hard for this bill for many years, not because of the high respect I have for our wonderful nurses in New York State, but really on behalf of the ultimate beneficiaries of the healthcare delivery system, the patients. I withdraw my request and proudly vote in the affirmative.
Mr. Weprin in the affirmative. Ms. Glick.
Thank you, Mr. Speaker. I want to congratulate and thank the sponsor. As we see changes in health care, we know that much of the services that patients receive are on an outpatient basis. So the people who wind up in the hospital are actually tend to be sicker than they were a generation ago because they're not readily admitted under today's scheme. And so the ability of a nurse, and the nurses are the backbone. Everybody who's had a relative or a friend in a hospital knows how important the nurses are. And so they are dealing with sicker patients. It is very important for them to have the ability and time to spend to ensure that each patient gets sufficient attention. So I withdraw my request, vote in the affirmative, and again congratulate the sponsor.
Ms. Glick in the affirmative. Mr. Cahill.
Thank you, Mr. Speaker. I, too, rise to first congratulate the sponsor and the many advocates who have been patient over the years to see this legislation make it this far. Let's hope it keeps going and that we see similar action in the Senate this year so we can start to assure safe patient care in our hospitals. You know, if you're a responsible hospital, this is going to be an easy measure to comply with. If you are already advocating for your patients in the appropriate way, you have safe staffing. If you don't, then this bill is for you. If you have abused your staff, if you have required them to work hours that they shouldn't be working, if you have limited the number of people who are going to be on the premises when you know you need more, then this bill is for you. This is where we fix it. I don't know of any colleague that would stand here today and argue that we should have inadequate buildings or inadequate equipment. Well, healthcare is not buildings or equipment. Healthcare is people and the care that they give. And I withdraw my request and proudly vote in the affirmative.
Mr. Cahill in the affirmative. Mr. Gottfried.
Thank you, Mr. Speaker. You know, earlier there was a discussion of why are we focusing on staffing for nurses and not doctors. Well, let's be real. Doctors are people with generally in the hospital community with wealth, with power, with status, more often than not, a Y chromosome. They are on a par with the Board of Trustees members. And so they have the clout to protect themselves. The nurses, who are the backbone of the institution, who are the single most important factor in whether the patients go home well or don't go home at all, they are the working people who are the easiest for management and the trustees to take advantage of. And it is our mission here to give them the power that the current arrangement does not give them. That is basically what the mission of state government is, to fight for those who can't fight for themselves as effectively as they need to, and to fight not only for themselves, but for us. Safe staffing saves lives. When cutbacks mean fewer nurses, more people die. When staffing is more adequate, more people get to go home. That's what this bill is all about. I congratulate the sponsor for doing such a fantastic job in this debate, and I am delighted to be here after almost 20 years that this bill has been around to watch it pass the Assembly tonight.
Mr. Gottfried in the affirmative. Mr. Ortiz.
Thank you, Mr. Speaker. I'm talking about being sick. I was in the hospital yesterday being taken care of by some nurses because I could not be here early enough. But I will make my statement very, very brief. I also would like to thank the sponsor. I also been here long enough to see this bill being stuck. Finally, we're seeing the light at the end of the tunnel. I also would like to thank the Speaker for allowing this bill finally to come to the floor. I also would like, if I would be remiss, if I don't thank my niece Rosa, my niece Nancy, and my Aunt Carmen for calling me, sending me email, and keeping me up to date that make sure I vote positive on this bill today. They are nurses at Methodist Hospital, my Memory Hospital, and also at Lutheran Medical Center. So today is a great day for New York. It's a great day for nurses, and thank you to all the nurses who came to advocate on behalf of this bill on the year after year since I've been here for the last 20 years, as well as those who just got here to see that this bill has become to be real in New York State. I hope that the Senate will take the same stance as we moving forward before session end, that we all can celebrate together and have a victory, not just for the nurses, for all the patients in New York State. Thank you, Mr. Speaker. I'm voting in the affirmative.
Mr. Ortiz in the affirmative. Mr. Rivera.
Thank you, Mr. Speaker. It's very simple. Let me see if I can still read without glasses. Safe staffing for quality care. Simple. It's been more than 2 years that I've been involved on this issue in the streets of New York, especially in the borough of the Bronx. I've been a patient in Montefiore Hospital. Montefiore Hospital is growing every day. It's buying all over, opening up community services all over the Bronx. I don't know about the rest of New York. And that's great. But that hospital, the nurses have been picketing time and time. And I have joined them. And better yet, if you go to YouTube, Rivera J78, you see that I have videotaped all their demonstrations as they attempt time after time to bring to our attention the danger that is taking place inside the hospital. They are overworked. They need additional staff so they can provide the services that they would like to provide. Me personally, I'm grateful to these nurses. I spent 14 days years ago in Montefiore, and I came out stronger, and I can dance salsa just about every day of the week. So I got a lot to be grateful to these nurses. That's why I felt I needed to get up and say, come on. I hope none of you ever wind up in a hospital and you get a nurse that's overworked, can't take care properly of you. So, of course, I want to thank the sponsor, and I want to say that I'm going to vote yes. Thank you.
Mr. Rivera in the affirmative. Ms. Warner.
Oh, you forgot to stop that.
Thank you, Mr. Speaker, and my colleagues. I would like to add my congratulations to the sponsor on bringing this bill forward and on doing such a wonderful job this evening. It's all been said before. Safe staffing saves lives. This is about making the patient outcomes stronger and better. And so to all the nurses who stopped me at pancake breakfasts and chicken dinners and on the street and told me their stories, this one is for you. Thank you. And with that, I vote in the affirmative.
Ms. Werner in the affirmative. Ms. Harris.
Thank you. I rise to explain my vote and to really thank the sponsor for this vote. I share the spotlight of my own birth with my twin sister, who is 35 years an occupational therapist, who on Monday morning before I left, woke me up standing over my bed and said to me, safe staffing. You better vote yes, because nurses are the heart of her unit. So today we vote yes for nurses. Tomorrow we will vote safe staffing for occupational therapists, soon to come. So to my twin sister, I love you, sweetheart, and safe staffing is a yes by me. Thank you very much.
Ms. Harris in the affirmative. Ms. Solage.
I rise to thank the speaker, the sponsor, great work, and the advocates who are fighting every day for patient safety. I myself, almost over a year ago, I was in the hospital giving birth to my first child, and I can easily say that the nurses were there to help me, to be there for me. And I had a difficult labor. They guided me, they helped me in so many different ways, so I thank them so much. I heard the other side, and it was a lot of hospital industry talking points. We have to get real about this bill. This is a common sense piece of legislation that will ensure patient safety and make sure that our nurses are not overworked and undervalued. So I urge the Senate and every one of my colleagues to vote in the affirmative, and I will vote in the affirmative.
Solage in the affirmative. Mr. Barron.
I simply rise to say thank you. Thank you to our nurses. Thank you to those who have a thankless profession. Thank you for caring to patients who are mean, evil, disrespectful. Thank you for loving and caring for them anyhow. And I want to say thank you to the nurses of Brookdale Hospital. You never get the credit that you deserve. I've met some of the finest human beings who were nurses at Brookdale Hospital, taking care of their patients and not being appreciated, even though they give their heart and all their caring to them. And I want to thank a historic figure who was a nurse, Harriet Tubman. During the Civil War, Harriet Tubman took care of people who thought she was inferior, took care of people who enslaved her, but she still cared enough to take care of people during the Civil War. So to the nurses of this state, thank you. And I vote in the affirmative.
Mr. Barron in the affirmative. Mr. Soreto.
Thank you, Mr. Speaker. I, too, rise in support of this legislation. I'm a happy co-sponsor as well. I want to applaud you for bringing this to the floor. I've seen situations in hospitals recently where my brother was in a hospital where the nurse was moving around from patient to patient, and patients were yelling out, "Nurse, nurse, nurse." I mean, it would break your heart when you hear things like that because of, we live in a wonderful state. We live in a wonderful country. We should be able to afford the quality care for our patients. When I was at a rally in Buffalo recently, about a couple months back, it was said, the nurses said they really cared about those patients. Please hear our voice. Please push safe staffing for quality care. And it was said their voices were heard all the way from Buffalo, all the way to Albany. Well, today their voices are being heard. Those nurses are being heard today, and I congratulate everybody. Thank you.
Mr. Soretto in the affirmative. Mr. Phillips Steck. Oh, thank you, sir. Are there any other votes? Announce the results.
Ayes 103, noes 32.
The bill is passed.